Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay, all right. So I welcome one and everyone in the class today, and we're going to be discussing about the HSG, first the procedure, and then about the different films. So you know that HSG happens to be a radiographic procedure. Okay, we are going through an X-ray. It's a radiographic procedure, but that's not it's not like a CT. It's like an X-ray. So it is a radiographic procedure which we see the uterine cavity and the fallopian tube patency. Okay, it plays a pivotal role in assessing the female infertility, recurrent pregnancy loss, and certain other gynecological conditions. So we're injecting essentially a contrast media in the uterine cavity, and then we visualize it under fluoroscopy, and by fluoroscopy I mean X-ray. Okay. So what are the indications? Infertility assessment, RPL assessment, and suspected assessment. So if you feel that there is, some intrauterine adhesions like Ashman syndrome, or if you feel it's a endometrial polyps are there, fibroid is there, certain Mullerian abnormalities are there, HSG may be a modality to screen. I'm still not calling it the confirmatory modality. So one of the modalities to screen further. To know the tubal pathology, very, very important. And post-surgical evaluation sometimes, especially for the tubal ligation success or reversal success. And if you want to know certain uterine abnormalities, like maybe if you want to just, this last one I'll skip. Okay, let's not include this. Okay, let's just include the infertility assessments. You want to see the uterine cavity, you want to see the tubal patency, you want to see the tubal patency as it is also, and if there is any tubal pathology like hydrosalpings, okay, and maybe this salpingitis, okay, isthmus nodosa, that kind of a condition, or absent tubes, or very thinned out tubes, or just tubal defect, that thing. Then recurrent pregnancy loss mostly will tell you about the uterine condition. Maybe uterine cavity is having a septum, or it's arcuate uterus, or it's bicornuate uterus, or there are adhesions inside. In the same way, uterine pathology, whether it's polyps, is going to delineate it further. So if it's uterine polyps or submucosal or a mucosal, this thing, a fibroid inside, submucous fibroid, submucous polyp, intrauterine adhesions, it's going to be one step towards understanding what pathology there is. Then tubal pathology, of course, you have hydrosalpings, and if you've got any, twisted tube, or tubal anatomy is deranged, or it's just febrile phimosis, something like that. Right, now moving forward. So can you tell me, okay, let me ask this question. Can you tell me the contraindications for doing HSG? So I have my chat room here. Please tell me if you have the answers for the contraindications to HSG. Let me hear that. Okay. Where is my chat room? Okay, so the answer is pregnancy, very important, very good. Active PID or active genital infections. Okay, excellent. Allergy to contrast. I think everybody has written down the basic 3 important contraindications is absolute, pregnancy, pelvic infection, and active infection. Pelvic infection or active infection, but even allergy to contrast will come under absolute contraindications only. Then relative contraindications may be a recent uterine surgery. You don't want to, interfere there. Severe allergy to contrast, maybe I'll put it in the absolute contraindications. Heavy uterine bleeding, you can reschedule the procedure. Then what about the prerequisites of HSG? When a patient is coming for HSG, what do you want to do? You want to make sure that these 3 things are not there. Allergy is not there, absence of pregnancy is there, and active infections are not there. And the timing of the procedure, come on guys, tell me the timing of the procedure. Yes. Who will tell me what is the timing of the procedure, when you want this procedure to be done? Yes. Yeah, I'm still there. Yeah, basically what do you write down mostly, guys? Dates of periods. Why do you don't want any, the menstrual periods, the menstrual cycle to interfere between you and your procedure, and you don't want any retrograde menstrual fluid to be inserted back into the tubes, otherwise it will cause endometriosis, right? So the idea is to ask her to come after the periods have got over. That's true. After menstruation stops. So that means the timing of the procedure is in the follicular phase of the menstrual cycle, but after the menses have ended, and sure, no active menstruation is there to reduce the risk of any artifacts or infection. Correct? Then how do you prepare the patient? You give some light analgesics, like give her an ibuprofen 30 to 60 minutes before the procedure. That will reduce drastically a lot of discomfort. Okay. You can even give her a mesoprostol tablet just to fashion the cervix in such a way. Actually, you don't require to do that because it unnecessarily makes it very squeezy, soft, and unnecessarily increases a lot of contraction. So just to make this, sometimes it so happens that, you know, there is a lot of stenosis in the cervix. I have met with such a patient who had a lot of cervical stenosis, and it was very difficult even to put one uterine sound inside. And you need some, at least, you know, when you're putting the dye, was all coming out. So that was the only case I felt where I could have primed the cervix. But usually when you're putting down the mesoprostol, it also causes uterine contractions, and probably you don't want that. So giving an analgesics is fine, 30 to 60 minutes before, but make sure that the cervical phimosis is also not there. Maybe assess the patient once. Then explain the risks and benefits of the procedure of the steps. Take consent. Obtain signed consent, particularly highlighting the use of radiation, contrast dyes. It's a radiographic setup, isn't it? And then, of course, you need a proper setup with sterile equipment, sterile set of HSG in which you have all the cannulas of the uterine sound. Then you have gloves, you have syringe. You know, you have this one bowl and one certain gauzes and betadine because you want to clean it up, and then certain sheets. So you require all these things. Now, what are the steps? You position the patient in a lithotomy position. You clean the vulva vagina with antiseptic, and you drape the patient. Then you insert a speculum to visualize the cervix, and you clean the cervix with antiseptic. You stabilize the cervix using a teneculum and then insert a cannula. You usually have these HSG cannulas. So they usually come in 3 sizes mostly. One is very narrow, one is a little in between, and one is a little dilated one. You take mostly, because they're all unmarried since nulliparous females were coming to you. So mostly you require the most narrow one. So usually you start with that. Ensure the catheter is securely positioned, and you attempt to have a backflow. So you'll have to screw it a little inside the cervix. It might cause a little pain to the patient. Explain her, be gentle, do not hurry, do not rush. Give time for the patient to understand what she's going through. Do not be brutal with the patient, as most of the people, they are, especially in the government setup. And then make sure one thing that you have to do, and you have to do a little fast and brisk, will be to inject the dye. Don't be slow there. Why? What happens is that when you're pushing the dye inside, you want the uterus to be distended, and it'll only distend with very gentle. Like this is what I used to do in my initial days when I was actually learning in a private setup. Very VIV patients used to come. That it was very, very gentle. So people used to call me for HSG most of the time because it was very gentle with the patient. But what I was doing initially was I was giving the dye also very gently. So most of it would fall back. It won't distend the cavity, or it would distend the cavity, but not the way it should be. Okay. And they're taking X-ray films and X-ray films again and again, but it's not distending the way it should be. Then I understood that the pressure is very important to distend the uterine cavity so that uterine cavity can be seen together. See, if the tubes are patent, the dye is going to flow through them. But the uterine cavity will never be seen properly if you do not distend it properly. So slowly they say inject a radiopaque contrast dye, but according to me, it should not be slow. It should be with good pressure and should be injected fast so that uterine cavity can be distended and seen. And of course, it will make its way through the fallopian tubes as well through the same pressure. And monitor real-time fluoroscopy to observe the passage of contrast to the uterine cavity and fallopian tubes. Obtain images of the uterus, and they usually have 4 images. One is the image when you've not pushed any dye, just to see whether it's correct or not. Then when you've started pushing the dye initially, then when you've distended the uterine cavity, and the 4th one when the tubes have been, the dye has leaked from the tubes. And you obtain the images of the uterus in different ways. So you have anteroposterior, you have lateral images as well. And I think it's given towards the end or somewhere that you have at least 4 images. And then you remove slowly. Once you've done with the procedure, you remove slowly. Okay. So, I was reading it from somewhere, and what they said was some 3 to 5 ml. 3 to 5 ml dye is nothing for uterine cavity. Okay, you require sometimes 20 ml, 10 to 20 ml at least to distend the uterine cavity, and then finally flows through the tube. Nothing less than that. Okay, so you try to omit this ml wala thing when you're speaking in the exams because books are saying something else, but practicality is something else. But yes, if examiner insists on it, then 10 to 20 ml dye is a must when you're pushing it inside. Okay. 10 ml, okay, fine. You start with 10 ml, but you see the 10 ml syringe, you will not be able to get the desired result. So 20 ml to be on the safer side. Start with 10 ml. If it gives you the desired result, it's fine. Otherwise, you'll have to push in 10 ml more, and then it'll distend the cavity or be seen through the tubes. That's for sure. So then remove the catheter very carefully, allow the patient to sit up, monitor for some immediate reactions, ask her how she's doing, document it in the notes what you saw, okay, and then counsel, debrief the patient, and then you can see antibiotics is not a must. In Indian setup, we do give. So do give her a painkiller for sure for the day. And if she has some, foul smelling discharge, a lot of pain, then maybe you can give her prophylactic antibiotics if she has a history of some pelvic infections already, but not an active one. Ask her to come back, after the next periods and encourage hydration to flush out the period. Yeah. See, they will not agree with 20 ml, but practically 20 ml is, usually required when we do HSG. And I'm sure you must have all done HSG at some point in time. You also know how small 10 ml is, and sometimes it does not give you a proper result. So practically speaking, I usually go for at least 15 to 20 ml, but you can speak in exam as per 10 ml. See, what is written in the procedure was only 5 ml. Because you're giving a dye, the contrast dyes. You wouldn't want to give it a lot. As simple as that. That's the answer. All right. Now, how do you follow up? The interpretation of the result is whether it's a normal finding, whether it's an abnormal finding, okay? And you need a further investigation. See, how will you do that? You'll talk about the uterine cavity and you'll talk about the fallopian tube. Okay, so whether you saw polyps or you saw fibroids or you saw that this cavity is irregular, or you saw it's biconvate uterus or it's a septate uterus, or you found that the tubes are blocked, or you found that the tubes are okay but the fimbria are blocked, or you saw that it's hydrosalpingogram, everything. That's so many things that will come, and that is what we're going to discuss in the slides to come. Okay, so you're seeing that. Okay, so what you're seeing is actually the tubal blockage. Consider laparoscopy. Now, what you're having is, if you're seeing a tubal blockage, you can ask her to go for maybe a lab dye test. Okay, if you're seeing a uterine abnormality, ask her to go for an MRI or 3D scan. Confirm the findings, right? And then, of course, you will call her for viewing maybe after the next cycle. Okay, and you've got to counsel her regarding her current position, and that is not actually up to you. It's up to your consultant how she wants to go ahead with that.